dermatology and medical practitioners about, vulval dermatology and genital dermatosis. She is a state and national board examiner for the Australasian College of Dermatologists, and she also serves at the state faculty. And what's very interesting is in her spare time, she is a keen sports photographer, and she is known to specialize in winter snow sports. Now, if you look at her Instagram feed, you will see that it has amazing photographs of the Olympian athletes from various sports centers and Australia. So it's something you don't want to miss on her Instagram page. And her blog as well is just filled with so much useful information in dermatology and cosmetology. It is definitely something that we should check out. So it's my pleasure and honor to have introduced Dr. Elizabeth Dawes-Higgs. And without any further delay, let's go right ahead to today's talk.
Hello, everyone. I am so honoured to be giving a talk about an update on vulval dermatology and to be part of this wonderful series of global dermatology talks. Now, I am from Australia. Specifically, I'm from Sydney, although I do spend most of my time in the Snowy Mountains as well, which is an area south of Sydney, south of Canberra, and it's quite cool there. And I'll be taking you through vulval dermatology, but I've scattered my talks with this talk with photographs that I've taken. But before I go any further, I would like to acknowledge the Gadigal people of the Eora Nation, who are traditional owners of the land that I'm sitting on right now. A little bit about me. I'm a dermatologist. I've got 20 years experience, and I am an ex-board examiner for the Australasian College of Dermatologists, and I'm also a member of two quite prominent societies who are very committed to vulval disorders. I run a vulval clinic, and I also am the co-founder of a practice, Northern Sydney Dermatology and Laser. Now, this is my practice in Sydney, so we're about 7 kilometres north of Sydney in a beautiful area called Northbridge. And this is turning around the corner, looking down the corridor, and we've got another corridor going left down the end there, and then another whole area about the size of this again. So we are one of the biggest dermatology clinics in Australia. These are the dermatologists that work at Northern Sydney Dermatology, and you'll see on either side here are the two principals, Dr. Shreya Andrick and Nina Wines. Before I go on any further, like I said, I'll be scattering photographs through the talk. These are ones that I have taken myself. I actually take photographs for Getty Images, and my passion is sport photography. But for the purpose of this talk, I've gone out and taken some photos for you of Australia that hopefully are ones that you haven't seen before. So these are in my backyard. So this is a kangaroo that's in my backyard. He almost came out just specially for me for this talk. And this is literally my backyard. This is Kosciuszko National Park, and it is really a beautiful place to live. And I spend half of my time here. Now, in this bush, you'll see emus, wombats, echidnas, kangaroos, and also snakes. So I've run over a couple on my bike. There's a path that goes through this bush, and you'll see down at the bottom of the screen there's my kids going along the pathway. This one in particular is about 10 kilometres long. So let's get started. Anytime I give a talk on vulval dermatology, I do like to start with vulval anatomy, just as a refresher for the medical students and residents and trainees that we have in the audience. I'll then talk about classification, and this is the ISSV classification for vulval disorders. We'll look at an update on pre-invasive lesions, because there's always a lot going on with that, and it can be quite a difficult topic to understand. There's a lot going on at the moment with the microbiome, and then I'll talk about the Australian contribution to vulval dermatology. So the vulva is the female external genitalia, as you all know, and this is a little bit about the anatomy. There's the clitoris, clitoral hood. The vulva is defined laterally by the labia majora, and then posteriorly by the perineum. Now, there's the vestibule, which is in the center there. The vestibule is non-keratinized skin, and it is bordered laterally by the labia minora, and it contains the urethral opening and ducts of the skin and Bartholin glands. Now, everywhere around the world, there are walls of wrongly named vaginas. This is obviously the vulva, and we have our own. In fact, credit goes to Greg Taylor because he was one of the first to do this. And this display is down in Tasmania, which is at the very lower part of Australia. It's a little island of Australia. And in the capital city of Hobart, there's a lovely museum called the Mona Museum, and that's there for you to have a look if you ever get to come over to Australia. So the ISSBD have classified the vulval disorders, and that's into symptoms, examination, and then particularly with examination, just how to do it. And I have just slightly modified it a little bit so that it's easy, and it's a great little way. This is how I teach my students on vulval conditions. So when a patient comes to see you, most of the symptoms are itch or pain. Sometimes it's burning, sometimes discharge, sometimes dyspareunia as well. And the examination, very broadly speaking, just to make it really easy, if you don't see a lot of vulvas, it's either skin coloured, it's white coloured, red, eroded or ulcerated, or it has blisters or bumps. And then using that, you can then go into those and have a nice clear differential. So skin plaques, for instance, lichen simplex chronicus, where skin-coloured papules and nodules are things like HPV, molluscum, and skin cancers. There's white patches and plaques, so this is vitiligo, but you can also get lichen sclerosus. Red patches and plaques and red papules. And again, a list of differentials to help you so that you just have a look, you decide what's the main feature, and then you've got a nice differential there for you. Red nodules, dark coloured lesions, these are nevi, but you can also get skin cancers and precancerous lesions that can have some colour in them. Edema, allergies, Crohn's disease, hidradenitis. This is Crohn's disease. Then vesicles and bully, this is HSV. Then you've got lichen planus, quite eroded. And then aphthous ulcers, so a nice illustration of an aphthous ulceration. So let's have a look at some examples. So if a patient presents with itch, the examination here, mainly this is a white, very clearly demarcated. There's loss of architecture of the vulva, there's scarring, and there's changes around the clitoris. And so this is lichen sclerosus. Another example, patient presenting with itch, but it's quite different. These are erythematous plaques with overlaying scale. If you look hard enough, you'll see this silver scale, very well circumscribed, and this is psoriasis. Now, if you look here, mainly red. Yes, there's a little bit of white, but there's mainly red here. And it is an erosion as well. There's loss of architecture, and this is lichen planus. So back to some photographs. So this photograph I took, this is the Snowy Mountains. It's actually the front valley of a ski resort where the beginner skiers learn to ski. And you can see in the background, there's all of the machinery for the chair lifts. And there's my son, he plays a frisbee on the front valley in summer. And then just a couple of weeks later, this is what it looks like. And that's exactly where my son was standing. It's now all covered in snow. So let's have a look at pre-invasive vulvar lesions. Now, there's a consensus study that was statement that was put out. 4 large organisations got together and put out a statement for pre-invasive vulvar lesions, and that was only a couple of months ago. And the aim of the statement was to improve the quality of care for patients and to help clinicians to better understand pre-invasive vulvar lesions. And the statement involved vulvar squamous intraepithelial neoplasias, vulvar Paget's disease in situ, and melanoma in situ. Now, for the purpose of this talk, though, I'm just going to talk about the squamous intraepithelial neoplasia because that's the area that really has changed a lot. So the history of classification of squamous lesions of the vulva, look at that. There's every year it's changed. So it's really hard to keep up with it. It's very hard to understand it as well. But I want to try and simplify it for everyone. So if we really just start at 2014, 2015, where we have WHO and the ISSVD, they replaced the term neoplasia with lesion. So there was no longer, that neoplasia lesion term. And so they replaced it with low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion. But the ISSVD also popped in, rightly so, another category, which is differentiated VIN, and I'll talk about that a little bit later. Now, recently the WHO has classified it, WHO has classified it again, and now we've got HPV-associated squamous intraepithelial lesions and HPV-independent VIN. So they either HPV is involved or it's not. So low-grade squamous intraepithelial lesions, they're not neoplasia, these are lesions, they're warts, and they're associated with low-risk HPV virus in about 90% of cases, and that's 6 or 11. And they don't progress to invasive cancer. They're very common, although getting less common nowadays, and it doesn't equate to VIN1. High-grade squamous intraepithelial lesions, these are HPV associated. They occur in younger women than the BVINs, which I'll talk about, and they occur in the introitus and labia minora, and they are multicentric and multizonal. And what that means is that they can occur in other areas as well. So they can occur in around perianal area, vaginal area, cervix. It's an increased risk of anal SCC and their precursors, and about 10% of these will progress to invasive carcinoma. So excision is one option, but for HSIL, there is also imicromod and ablative laser as a treatment option. And so this is from the consensus statement paper itself, showing high-grade squamous intraepithelial lesion. So the consensus summary from this publication was that if you have HSIL of the vulva, you need to inspect the entire lower genital tract. So the anus, vagina, you need to do colposcopies. And if you're going to choose a non-excisional treatment modality, then the recommendation is to have multiple mapping biopsies to exclude invasion before you go ahead with that non-excisional treatment option. They did recommend imicromod as an option to preserve normal vulval anatomy, and also that if excision was chosen, that when the pathology comes back, if you do have positive margins and there's no clinical evidence of HSIL, then you the recommendation is that you don't need to re-excise. HPV vaccination was recommended to aim to reduce recurrences, although that wasn't a uniform amongst the authors, and that there needs to be lifelong surveillance of these patients. Now let's look at DVIN. So this is differentiated vulvar intraepithelial neoplasia, and this has no relation to HPV. So these are related and associated with women who have other dermatoses, such as lichen sclerosus or lichen planus, and this occurs in older women. Now, it's not as common as HSIL, but it is much more important because they have a higher risk of progressing to malignancy. In fact, the risk of progression to malignancy is about 50%. And so because of that, excision is the only option recommended for these lesions. And there is a risk of recurrence, and it's higher than HSIL. This is from the paper showing a differentiated vulvar intraepithelial neoplasia. So the consensus summary then for differentiated VIN is that complete surgical excision is recommended, and that this also allows for the exclusion of any invasive disease as well. So they also recommended that there is good control of lichen sclerosus and lichen planus after you've treated the differentiated VIN, and that's to reduce the risk of recurrence and progression. And that's with high potency topical corticosteroids. So this is a hut. So all through the mountainous regions of the high country, we call it high country or alpine regions, alpine areas of Australia, are these scattered huts. There's about 200, but there's probably more than that because this country is vast, it's really vast. And these were constructed in early 1900s. This is one, it's called the Cascade Hut. And if you do get the chance of coming to Australia, it's well worth getting to this. You have to go on a 10-kilometre hike to get here, but it really is a beautiful hike and lots and lots of different scenery. And it's being built to provide shelter for stockmen or travellers, adventurers, skiers, anyone that gets caught out in the bush can go in and take shelter. So let's have a look at the microbiome update. And this was, there's a complete series in 2022 in the Journal of Lower Genital Tract Disease, and a commentary by Dr. Jack Sobel, who's an expert in this area, who said that the vaginal microbiome has been relatively late to the party, and that's actually quite true. But what is the vaginal microbiome? Well, a microbiome in general is the entire habitat. It includes the microbiota, their genomes, and surrounding environmental conditions. And the microbiota are the actual microorganisms in that environment. Now, it's very difficult to define what's normal for the vagina. So the consensus at the moment is that the normal microbiome is taken to be the microbiome in the absence of vulvovaginal disease or symptoms. Now, we're not quite sure whether it's going to be disease or symptoms, and that's still to be determined. And it's mostly in the vagina lactobacillus dominant. So lactobacilli in vaginal health, there's 20 species have been found, and most women have dominance of one of these species, and that is responsible for a pH of less than 4.5 in the vagina. And there's 5 community state types that have been sort of elaborated on, and 4 of those involve lactobacilli dominance, and there's one that is not lactobacilli dominant. And you're probably wondering, you know, why am I talking about the vagina when this is a vulval dermatology talk? Well, these areas are intimately related, and what goes on in the vagina invariably has an effect on the vulva. And so this disorder is being discussed quite recently across a number of papers. It's called desquamative inflammatory vaginitis, or DIV. I'm going to call it DIV from here on for ease for my talk. And it is associated in some way with a disruption of the microbiota, and it's still to be established. But what happens here is that you have a lot of vaginal discharge and pain. And of course, when you have discharge, it's going to affect the vulva, and you get a lot of irritation and swelling of the vulva. Now, it's an inflammatory vaginitis of some etiology, but not infectious. Candida albicans in the vagina, again, get a lot of discharge and involvement of the vulva, of the skin by the candida, and also irritation from the discharge. And this is the most common fungus in the human microbiome. Our microbiome is a fungal community in the microbiome. And Candida albicans is present in about 20 to 30% of asymptomatic women. And this Candida is inhibited by the microbiome by the production of lactic acid and a few other things as well. So about 80 to 90% of vulvovaginal candidiasis is caused by Candida albicans. Now, some of this can be treated with fluconazole, and some it can't, which brings me then to the two new treatments for candidiasis that are out now in the last 12 months. They are available. We don't have them in Australia yet, but they're available to you. And they're these two. I'm not even going to pronounce them, but there's two there. One's an azole and one isn't. But let's just run through the background of what are we doing right now and why do we need two new treatments. Is that the guidelines at the moment for candidiasis is a topical antifungal or a single dose of fluconazole, which is 150 milligrams. If it's severe, then that 150 milligrams is every 72 hours for 2 to 3 doses. But there are cases where the candida just doesn't respond to the fluconazole for whatever reason. It can be resistant, but also it's not Candida albicans, there's another candida involved. And so boric acid, 600 milligrams into the vagina daily for 14 days, or nystatin with a similar regime. Now, if you have recurrent vulvovaginal candidiasis, so this is candida that keeps going more than 3 to 4 attacks per year, then you're going to do the above for 2 weeks and then continue on a weekly dosing of fluconazole for 6 months. So that's the current recommendations with fluconazole. And so then the goal is to try and have something that you can use in pregnancy. Unfortunately, these two new treatments have not addressed that. We still don't have options for pregnant women. But what these do is that they allow for better sort of control of candidiasis. There aren't any head-to-head studies with fluconazole at this stage, but it is looking like they are much better tolerated, minimal side effects. And this a one-off dose of 300 milligrams twice 2 times for just one day. The other one is an azole, and it works a little bit better because it inhibits fungal CYP51, which is an enzyme required for fungal growth. So it works a little bit better than fluconazole. Mechanism of action is a little bit better, and it has a different regime, but again, it's not for pregnant women, and it has a really long half-life. So it means it's not for women with reproductive potential, which just about excludes all women except postmenopausal women. This is called the Blue Lake, and this is about 10 minutes drive from where I live in the Snowy Mountains. And it's a beautiful, beautiful lake. So this is a photograph that I took. You can see some hikers down at the bottom of the screen. And this is believed to be the freshest water source in Australia, and it is a circular lake. There's only 4 circular lakes in Australia, and it has been carved out. This lake has been carved out in the Ice Age from a glacier, and as the glacier comes down, it sort of bottoms out and causes this little dent, which creates a lake. and it's a beautiful area, beautiful walk. So let's look at the Australian contribution, because at the end of the day, I'm giving an Australian perspective to vulval dermatology. We're going to look at DIV again and PCV, which is plasma cell vulvitis. And I'm going to revise both of these terms, but this is the article that is from an Australian group. It's a group from Newcastle, and they're a very clever group, and they have a pathologist and vulval dermatologist along with quite a number of other researchers. And this was published this year, and they were looking at these two disorders. Are they the same thing along a spectrum called hemorrhagic vestibulovaginitis, or are they two completely different entities? So let's just revise. I thought it would be a nice opportunity to revise plasma cell vulvitis. This is also called Zune vulvitis, and you might have heard about Zune vulvitis before. And these women present with pain. This is particularly pain and burning and dyspareunia. And it involves the vulvar vestibule, which is a mucous membrane, and the labia minora, which is a modified mucous membrane. So this is a vulval condition, and the name suggests it because it's vulvitis. It presents with these very classic, well-demarcated, shiny, reddy, tinged macules and patches. When you see it, you'll know it. And then you've got the DIV, and this is a vaginal issue. So it's a vaginitis, and this is abnormal discharge, a lot of discomfort, a lot of pain and dyspareunia. And they get this purulent white-yellow discharge, and a lot of erythema. It can be confluent or it can be spotted around. And so how do we diagnose it? Well, Dr. Jack Sobel put together diagnostic criteria in 1994, and then an Australian vulval dermatologist, Gail Fisher, put together a revised one for Australian dermatologists in 2010. So the diagnostic criteria for DIV is this purulent discharge, vaginal inflammation, a vaginal pH greater than 4.5, and a point of care microscopy, which shows parabasal cells. And these parabasal cells are a sign that the epithelial cells are desquamating off. So it's an exfoliated epithelial cell, and they're really small. They're quite distinctive. And the diagnosis is also made with the exclusion of other dermatoses, such as bacterial vaginosis or candidiasis. Now, in 2010, Gail Fisher put out an article to help with the diagnostic criteria for Australians, because we don't, for whatever reason, use microscopy in our rooms. And so this is a modified criteria whereby it didn't involve the examination of the parabasal cells. So you have this classic history, the classic clinical findings. You're excluding other dermatoses by not having scarring, it doesn't cycle, there's no drug involved, there's no irritant involved, and that you're also excluding other infections with swabs such as candidiasis, and there's a treatment response. So you start a topical antibiotic and you get a treatment response. And so back to the 2022 paper, they're looking at similarities between DIV and PCV, and there are a lot of similar symptoms and similar treatment response, and very similar across the board in terms of this inflammation and what's causing it. So the hypothesis is that they're actually two diseases on the same spectrum, because they occur in the same sort of women, same age groups. They have overlapping symptoms, pain, discharge, pruritus and bleeding. The examination is very similar. It's just in different areas of the vulva or vagina, and similar histological features depending on that site of biopsy as well, and very similar response to topical steroids or topical corticosteroids. So there's this term that's proposed, and I put it out there so that if you hear the term, you'll know what it means. It's hemorrhagic vestibulovaginitis. So it's a very descriptive term, and it's proposed that it's a spectrum of disorders. And it's not intended to replace the term DIV or PCV, but it's to help us as clinicians in the treatment of patients, so that DIV tends to present more to gynecologists, and PCV tends to present more to vulval dermatologists. And if you make that diagnosis, then you know that if it's DIV, you've got to inspect the vulva, and if it's PCV, then you'll need to inspect the vagina with a speculum. So there's an elaboration then on the diagnostic criteria. Again, the clinical, excluding infectious etiology, but now we're including pathology. And so there's from this paper, they looked at pathology because they do have a prominent world leader in vulval pathology in Newcastle, and so they're able then to include a pathological criteria to the diagnosis of DIV and PCV. This again is in the Snowy Mountains. This is Perisher Creek. It is actually normally a creek with it's a little bubble, but at the moment, because of all of the flooding that we've had, this is absolutely overflowing. And there's a fisherman here. So national parks don't like or that we protect our wildlife, but the trout that are in there are introduced. So everyone turns a blind eye to fishermen, and there's lots of trout in there. Let's talk about lichen sclerosus now, and still Australian contribution. So this is a consensus of Australian experts, and I was involved in this research. And this looked at lichen sclerosus to help Australian clinicians. So just a recap of lichen sclerosus, we've already seen this image. It's well defined. There's white sclerotic plaques, a lot of anatomical changes, and cellophane paper wrinkling here. And we talk about this figure 8, which you can see in the image. So this consensus involved 22 Australian experts in the field of vulval dermatology, and the aim was to have this unified agreement amongst the experts to help with a severity scale, and that was to assist with further assessment, research and treatment. And the aim also was to have a unified agreement on long-term management, so that we could develop these broad guidelines on short and long-term management for clinicians. So this was published in August last year, and the main one was that at the first presentation, you didn't necessarily have to have a biopsy to confirm lichen sclerosus, that a photograph was as good as a biopsy, and that helps with ongoing management of the patient. Now, initial management is potent, ultra-potent topical corticosteroids, and then long-term is individualized depending on flares, and also noting that some women can be asymptomatic, but you still need to treat in the long term, and the follow-up is indefinitely. We put out a really nice management pathway for adult vulval lichen sclerosus, which is in that consensus if you want to look that up. There were also a few pearls from the World Congress that I just wanted to include here on lichen sclerosus. And the pearls were around the association of lichen sclerosus and malignancy and cancer risk. So many of you will know that there is a malignancy risk, and it's 4% for lichen sclerosus, and you're tailoring that message to the patient. So you want to have this balance where it's not too alarming, but by the same token, they need to understand that there is a cancer risk and that they do need to be followed up indefinitely. So you want to be very clear with the lichen sclerosis information and to give handouts, because it's been noted that there's a lot of misinformation about lichen sclerosis out on the web, and that at each visit you are looking for cancerous changes. You don't need symptoms for diagnosis, and not to be afraid of using topical corticosteroids in the vulval area. Let's look at lichen planus. So little recap, lichen planus is a disorder that involves both the vagina and the vulva as well. It's very well demarcated. You get this quite distinctive sort of glazed erythema, eroded look, and there's this surrounding whiteness. It is symmetrical and bilateral. There are vaginal adhesions, and you can have a reduced introitus as well. So the treatment involves topical corticosteroids, but quite often patients need to be progressed to systemic treatment, which is quite different to lichen sclerosis, which is acutely responsive to topical corticosteroids. Whereas lichen planus, you often need to go to systemic agents. And so then there's treatment challenges with this. With lichen planus, the scarring implications. And so because of all of these general issues, this paper was looking to address some of those. So this is Gail Fisher's group, and they're about 1 kilometre away from where I am. They're in Sydney, and they wanted to look at predictors. What are the predictors for systemic immunosuppressive treatment requirements of vulvovaginal lichen planus? And it's based on, so this was published in the Australian Journal of Dermatology this year, and it's based on the fact that about 20 to 40% of women fail to respond to topical corticosteroids. And so what are those risk factors? So this group put out, undertook a retrospective cohort study of 122 women, and they concluded that actually, yes, there are predictors, and that is that it's a decreasing age at diagnosis. So younger women tend to need systemic immunosuppressive treatment more likely. Non-Caucasian ethnicity was another predictor, dyspareunia and pruritus as well. So this group may benefit from an earlier initiation of systemic therapy. Let's look at vulvar cancer. So this was a presentation by an Australian vulval dermatologist at the recent IWSVD World Congress. And she spoke about lichen planus and vulvar cancer, and is there an association? Looked at all of the published studies, and very cleverly looked at these studies. And the summary is that from the studies that we have, we can't be sure that lichen planus is a precursor or a cofactor for vulvar cancer. Doesn't mean it is or it isn't, it's just that we don't have that information. But the thing is, does it matter? And it's viewed that maybe it doesn't matter right now. It would be nice to know that, but maybe it doesn't matter right now, because these patients with lichen planus are often in, or more than likely in, a specialist-led clinic for long-term surveillance, because they have treatment challenges, they have scarring, they often have other dermatoses such as candidiasis and HPV. And so by being in these clinics, it allows for early identification of neoplasia by specialists. So lichen planus seems to be associated with a risk of vulval cancer, but we just don't have that publication yet. It's unclear, is it related to HPV or is it not related to HPV? Another on vulval cancer, and this is a group from New Zealand, so I put that in here because they're sort of Australian. This was published only last month, and that was looking at vulval cancers, SCCs, and that there are two different types of SCCs, and they're HPV independent or HPV associated. And if they're HPV independent, so not related to HPV at all, they have a worse survival, and that was not related to the stage or age at diagnosis of the vulval cancer. So finally, I'm going to wrap it up now. This is another photo that I took, and this is again of the Snowy Mountains. This is in winter, and it's a really beautiful time to spend in Australia, winter as well, not just summer. So I'm going to wrap it up. This is the co-founder of Northern Sydney Dermatology. This is Nina Wines and I in our laser room. I've put my contact details here. You can contact me by email, and also put out information about general dermatology, and also some of my photographs as well. So thank you so much for having me. Thank you for staying through. It is now about 3 o'clock in the morning over in Sydney time. So enjoy your day. Thanks.
Oh, hi, everybody. I hope you had a great time at this lecture. There was a lot of new information and advances that we were able to listen to. So unfortunately, due to the time difference, we won't be able to host a live Q&A session. However, in the chat box, I have entered an email address. So you can direct the questions that you have here, and we will forward them to Dr. Liz Dawes-Higgs. So this is the email address. So any questions that you have, please feel free to forward them to this email address. And I think this was absolutely fantastic. I think all of us now want to, pick up our passports and probably head down to Australia and Sydney in particular, because it was absolutely beautiful. And I think this presentation is so unique in that we almost fell in love with Sydney and the beautiful landscapes that were presented today. So thank you so much. And thanks for the opportunity to let me host. Thank you.
Great. Thanks, everyone. Thanks.